Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we hear from Dr. Peter Goldswain and Dr. Olga Ward.
Hi, I'm Olga Ward and I'm with Dr. Peter Goldswain today. Peter, can we talk a little bit about dementia and delirium assessment management?
Thanks, Olga. Yes, there are usually two reasons why you're asked to look at people who have cognitive problems. One is that the concern of relatives and carers that people have got memory loss. That's probably the most common. The second is that given all the emphasis that's been given to dementia over the years with radio, television, papers and so on, newspapers and so on, people are worried about it, and we call these the worried well. And they will turn up at our memory clinic saying they have dementia and we have to exclude it. So we have the two groups. By far the commonest group is the first group.
Yeah, of course, us in GP land, we're usually the ones to whom the patient's relatives complain. We're also often doing driving medicals and things. And whilst I think everyone over the age of 45 loses their glasses and their keys all the time, some of the patients will raise quite legitimate concerns. In terms of a general practice assessment before the patient gets to your memory clinic, how does a GP assess for early dementia? What sort of clues are we looking for?
I mean, we all know about doing many mental states and all those things like that, but really the most important information is that from the carers or relatives. I mean, they are the most observant. Whenever we see elderly people where there's a question of dementia, we always insist that a carer or relative or friend comes who knows that person and who can then impart the sort of knowledge together with asking the patient questions and so on. So that's the most important side, is getting collateral information, and that really forms the basis of it. Mental tests are important, and there's a whole range of them. You're familiar with the mini mental state. There's a newer one called the MOCA, which stands for Montreal Cognitive Assessment. That's what President Trump did, and he did so well on. Remember? He got 30 out of 30 on that. Those are the two big tests. There's another test we use called the Addenbrooke's test, which is perhaps more difficult, but the mini mental state and the MOCA tests we use as well. All right.
I think that some of my patients have certainly learnt the mini mental state and to a lesser extent the MOCA screen. And one of them very kindly spelt, because they'd only been to about year 3 at school, decided that rather than doing some serial sevens, they would spell world backwards. But they spelt world backwards, meaning whizzed around rather than earth. And I wondered whether or not I should give them extra points for that. It's kind of difficult, and I guess a general practice patient sometimes will present with signs that sound or look like dementia. Are there any very chronic things that might cause a low-grade delirium or a low-grade cognitive impairment that's a physical illness that we should be screening for to exclude?
Yes, I think that's right. I mean, not everybody who has supposed memory loss has got early cognitive function compatible with dementia. I mean, things like anxiety and depression will quite frequently present as though they are dementias, and we actually call depression pseudo-dementia. So that was recognized 20, 30 years ago. So things like anxiety and depression can contribute to your memory loss, and we have ways and means of distinguishing these by doing depression tests, the type of memory they've lost, because depression loses both their long-term and their short-term memory, whereas dementia loses their short-term memory. So these are the little differentiating features which we can tease out. So yes, there are, and then there are obviously the more abstruse things like tumours and secondary things and metabolic dysfunction and so on. These are much rarer because Alzheimer's and multi-infarct dementia really form about 90% of all causes of dementia, and the 10% of the remainder are contributed to by about 99 conditions. So there are a lot of little conditions that can contribute towards the memory loss or the perception that you may be going a little demented.
If you're doing an organic screen, which GPs will frequently do before the patient goes to a memory clinic, what do you think is really important to include in that?
I think you've got to look at the patient as a whole first, make sure that their general health is good and exclude any obvious reversible factors, make their blood pressures all right, their diabetic control is good and so on. We ask GPs to do really things like a full blood picture, urea electrolytes, check their urine, do a blood sugar level. It depends really on the patient's background, their comorbidities as to what you test. But generally speaking, full blood picture, urea electrolytes, thyroid function tests. Thyroid is quite often missed as you get older, blood sugar levels, and then you can do odd things like calciums and vitamin Ds and so on. But really it's those that you try. And then depending on their background, you might look at sexual, at their syphilis control and stuff like that. But that's not routine. We will do that in specific cases where you suspect it. But that's really all you do. They do say that you should do CT scans, and you really do CT scans to exclude contributing causes like unexpected tumours, things like normal pressure hydrocephalus, subdural hematomas, and so on. That's why you do a CT scan, not to diagnose dementia, as you appreciate you can't diagnose it on a CT scan. And we like to do an ECG. Because the drugs we use in dementia have an impact upon your heart rhythms. So that's the basic. Those are the basic tests that we like to be done before we see them.
Once we've corrected the correctable things, could you just elaborate? I noticed that you mentioned vitamin D. Slightly controversial when GPs often get these little things from not the National Prescribing Service, but the people who monitor what pathology we ask for, and they tell us you shouldn't be screening for vitamin D, completely ignoring the fact that the patients that you've screened are often extremely low, even if they're fair and live in the country and are on a farm and are crawling with skin cancers.
Vitamin osteoporosis, which is why you're asking about vitamin D, is very important, and particularly in the frail elderly, we like to know what their vitamin D status is. So really, you can perhaps remove that vitamin D. I tend to do it because you're looking at frail people, and as an adjunct, I'll add the vitamin D to it. But I guess you're correct. It's probably not contributing towards their cognitive dysfunction. So yeah, I'll withdraw that one quietly. But I mean, I still think it's very important in assessing old people. But perhaps I'm drawing too much of a long straw there.
Occasionally some of our psychiatric patients are being supplemented in their depression with vitamin D, so I'm guessing that there may be some kind of cognitive role there.
Yes, I mean you can get hypervitaminosis D, but that's very, very unusual. I've been around for a few years, and I've yet to see anybody with hypervitaminosis D due to exogenous vitamin D. Yes.
Peter, is it important to differentiate the type of dementia? You know, I've had patients with Alzheimer type and with frontotemporal and Lewy body, and does that have any useful, say, clinical predictive value or things that will change the patient's management? Yes.
As I said earlier, Alzheimer's forms about 60% of the causes of dementia. Vascular dementia is about 20%. The mixed group between Alzheimer's and vascular are another 20%, and then the rest fill in the other 99. Well, we like to try and differentiate because of the medications. The PBS won't allow you to use the cholinesterase inhibitors in patients who haven't got Alzheimer's disease and Lewy body disease. So they should have either Alzheimer's, and Lewy body is a form of Alzheimer's. Just for your audience, and to remind them, Lewy body has 4 or 5 very significant features. They fall more frequently than Alzheimer's. They have a very high incidence of visual hallucinations. They have Parkinsonism, not Parkinson's, they have Parkinsonism, and they have quite a fluctuant course, and they are susceptible to the psychosedatives, the atypical antipsychotics. So those are the 5 differentiating features of Lewy body disease.
So if somebody had Lewy body dementia, when you say Parkinsonism, do you mean that they get the rigidity and the stiffness, or that they actually develop the tremor?
They actually look very much like Parkinson's. They have this sort of festnet gait and rigidity and may have the tremor, but the interesting feature is they don't actually respond to anti-Parkinson drugs. So they have Parkinsonism. When I first started geriatrics, we used to see these little old ladies and men with obvious dementia who had a Parkinsonian look about them, but we tried to work out what they were, and then only in the late 80s did somebody differentiate and come up with the Lewy body disease, because they actually found Lewy bodies in the cerebral hemispheres, which they hadn't been able to find until then. So the Lewy bodies of Lewy body disease actually occur in the cerebral hemispheres rather than the basal ganglia, where they do in true Parkinson's disease. So that's the differentiation, and the PBS allows us to use the cholinesterase inhibitors in those patients with Lewy body disease.
How effective are the cholinesterase inhibitors? I haven't found that they've created a great deal of improvement in most of my patients, although they've remained more or less stable.
That's true. It's said that only about 30% of patients with Alzheimer's or Lewy body, and sometimes I'll just tell you an aside, sometimes we'll see people who may have vascular dementia, but we call them mixed dementia because we want to try them on the medications, right? So we take a bit of license there. It's said that 30% of these patients, the disease is modulated, right? So all it does, it softens the disease. And in those 30%, it gives you another 6 to 9 months. So if you're living at home and you're just about to go to care and you do respond to the cholinesterase inhibitors, it might allow you to stay at home for a little longer and just modulates it. So those are the 30% of patients, but it doesn't cure it by any matter of means. It just modulates it, and like all drugs, it has side effects. And one of the side effects is bradycardia that I was mentioning earlier. And in the memory clinic at Royal Perth, we've had to pace a few people who've actually responded but have become significantly bradycardic, but because they've improved so much, we've decided to pace them as well. So that's. But you're entitled to be skeptical about the cholinesterase inhibitors. There is a 4th drug called memantine or Ibixa, which is an NMDA antagonist. And it's really used for those with severe dementia. It's used with many mental states of between 10 and 14. So you can appreciate that's quite at the lower end of cognitive dysfunction.
What other kinds of interventions might help patients who are developing dementia or who want to prevent dementia?
Okay. I think there's a simple rule. I think you have to stay cognitively and physically as well as possible. So exercise your mind in whatever you wish to do, crossword, Sudoku, reading, bridge, chess, and so on, and keep physically well. Those are the 2 pillars that we try and espouse to keep our patients well. And it's said that you won't actually prevent dementia by this, but all you'll do is you'll delay the onset of dementia. So whereas dementia goes, usually it's about 10 years is the normal natural history of dementia. And it's said if you do stay physically fit and mentally fit, that you will get dementia, but you'll get it later and you'll get it worse. So instead of a nice gentle curve of normal dementia, you will stay normal for a while and then suddenly dive down. So that's what it does for you, which is a better way, I think, of absorbing the disease.
Do you have any other tips for helping the patients remain independent in the community?
Whenever I whenever I see the patients, and certainly when I was working at Royal Perth, we spent a lot of time educating the families as to how to support their family, the patients with dementia better. So it really is, it's the understanding of the family, of the disease, of the progression of the disease, of the impact of the drug, and all the support services that can be done in the community. So it's keeping them healthy medically, and the support services through all the various programs we've got. There are behavioural programs and all the community supports that are available. So that's the best way of supporting, and to keep them at home as long as possible, because that's the place with they are familiar, the familiar faces, the familiar facilities and so on.
And can I just come back to the patient that we think might be delirious and we're not sure? Somebody, particularly with some of our older patients, there'll be somebody who we haven't seen very frequently in the medical context, and they come in often with their daughter or their son, and they'll say, she's gone off or he's gone off, and losing his memory, losing his marbles, whatever. When you're trying to assess that, are there any clues that this might be something that's a delirium?
Yes. As you appreciate, dementia is a slowly irrevocable disease and slowly progressive, and its course is like that. Delirium is an acute onset of dementia-like symptoms. So if there's acuity there, then you think of delirium. All right. So dementia is a slowly inexorable disease, irrevocable disease, whereas delirium is a rapid onset. And they've actually.
By rapid, you mean a few weeks rather than a few years? But
days.
Yeah,
yes.
Weeks could be still considered rapid?
Yes, absolutely. So that any acute fluctuations must be explained somehow. And there, when there was some emphasis on delirium on the mid-90s by Sharon Inouye in Yale University, she developed the thing called the confusion assessment method. It's very, very subjective and difficult to administer. And more recently, the Scots have come up with a thing called the 4AT. All right, and it's much more objective, we can talk a little bit about how we do it. But the 4AT are you measure the patient's alertness and whether they're normal, slightly sleepy or abnormal, and they get 0 to 4 points for that. The second A is the AMT4, and most of you are familiar with the AMT4. That's asking the patient their age, the date of birth, the place you're in, and their age, date of birth, the year we're in, and the place. That's the AMT4, and they get 2 points for that. And then you ask them for their attention, their ability to count backwards the months of the year. And if they get more than 7, they do well. If they don't, they lose a point for that. The other way around is ask them to count backwards from 20 to 1, and then they score points on that. And for attention, it's 2 points. And the last one is the one that I'm really referring to, is the acute change in the last 2 weeks. And for that, they get 4 points, and either no or yes. And what it is, so on the 4AT, if they get no points, then cognitive loss is unlikely. 1 to 3 points is possible cognitive impairment, and more than 4 points is possible delirium or cognitive impairment. So that's now embedded in our regional resource centres in WACS, the 4AT, and it's a very useful differentiating feature between delirium and dementia. But that's a test. The most important thing is you talking to the relatives and the friends as to find out what the course of their presentation has been, and then you look for all the possible contributing factors to their delirium.
So I noticed that part of that assessment involves some counting backwards or some months backwards, and we were talking a little earlier about things like mini mental states and MOCA screens. What happens to the patients, and we do have a fair number of them in rural areas, who really never got much beyond year 3 at school, or mother pulled them out to help with the younger children. they're simply illiterate and they're not really comprehending what you're asking. So how do you kind of differentiate whether it's have they understood the question or do they have the ability to answer the question?
The mocker, I mean, if they can do the mocker, we actually give them points for lack of schooling, so they get a few more points for that. But still, they may not be able to do some of the mathematical equations and things like that. There is a test which is an Australian one called the RUDAS, which stands for Rowland Universal Dementia Assessment Score. And this is for uneducated people or people who don't speak English. So the RUDAS, we use the RUDAS in those situations, RUDAS. And very handily, all these tests are out of 30. So, and they're all, we all sort of accept that anything under 25 suggests dementia but doesn't diagnose it, all right? So that's the RUDAS. There's a specific one which has been developed in WA called the KICKR, which stands for the Kimberley Indigenous Cognitive Assessment, and it's used for Indigenous people, and that's out of 39, and anything less than 33 is suggestive of but not diagnostic of dementia. Sometimes people with depression will just refuse to do it, but then you really are reliant on the collateral history. So, I mean, as I said before, you've got the two features to assessing people. It's the collateral history from friends, relatives, neighbours. I find the people in the rooms I work at in the country, the staff know more about the patients than some of the relatives know about them, because they've observed them irregularly, and in fact irregularly viewing people is more helpful than being too close to them, because they often miss the subtle changes, whereas those who see them irregularly are more informed, more aware of what's going on. So you may have problems, as you say, with doing these mental tests, but those are the very. So it's the mini-mental, the mocker, the RUDAS, the KICKR, or the sort of range of tests that we use.
Much of the time our patients are a little more remote than even the telehealth link in town or whatever, but assuming that they could maybe access Telegeriatrics rather than the geriatrician in person who's a couple of 100 kilometres away, how do you go about assessing a patient on the Telegeriatrics?
We started this program about 2 years ago in response to a build-up in the waiting list for patients to be seen by geriatricians on a face-to-face basis. So there's an existing geriatrician visiting program, but you can only go so often. It's quite expensive to send a geriatrician out of the country with all the costs involved, and we were faced in certain regions in WA with year-long waiting lists. So then we developed Telegeriatrics, and soon appreciated that it really was all about cognitive impairment. When we did our first year of Telegeriatrics, 85% of our patients had cognitive impairment. So it's, as you suggested, this is the major concern out there. How do we diagnose it? It really is, we get the usual referrals from the GPs with the baseline test that we've already requested. So the GPs knew about this from the previous visiting geriatric program, so they would do all their blood tests and the CAT scans and ECGs that I've already mentioned. But what we did in addition was that prior to seeing the patients, we would get them assessed by the clinicians, the OTs or the physios who sit in on the video consultations, and they would do a mini-mental state, a marker, a RUDAS, whatever was relevant. They would get all the GP's letters, previous hospital summaries. They would do a Bartels, which is, the Bartels is the assessment of their independence, so their ability to shower, dress, whether they need a support for it and so on. And they would also, on a tabular form, work out whether they were high risk for institutional care, medium or low risk. So you'd have your mini-mental state, you'd have your GP letter, you'd have the assessment of the supports that they get, their carers and so on. Then they'd also video them if necessary. They'd do a get up and go test, which is the get up and go where you stand up from a chair and walk 10 metres and turn around and come back. And they would do a balance test, not unlike a Romberg's, but at least more objective. So they would do all that in the pre-assessment about 2 or 3 days before the patient actually saw us. We then would see them on a video consult, and we would take an hour with them to do the consult. And we insisted that a relative or carer was there, just as I've said, for that corroborative feature. The clinician was there, and they would however many hangers-on needed to come. But usually it's about 3 or 4 people would fill the studio, and that's worked extremely well. So well, in fact, that we've analysed those patients and looked at their ED presentation and hospitalizations before Telegeriatrics, and then looked at the ED presentations and hospitalizations subsequent, and there's been a significant reduction in those 2 features since we've seen them. So we think it's working. The funding is a bit dicey. We're not sure how that's going to continue, but certainly the impact of the Telegeriatric program, we just do 1 Telegeriatric session a week, and we've dropped the waiting list from a year to a few weeks in some of the places. So it's had an impact on the waiting lists, on the cognition assessments, and so on. But there's no doubt the gold standard is still face-to-face. If you can see a patient, you do much better. I mean, one of the problems we had with Telegeriatrics is that people expected a diagnosis at the end. And when we started, we said, we think this is dementia. And the studio broke up. People were crying. The relatives were all upset about it and so on. So we no longer talk about the diagnosis. We say to them, please to go back to their GPs. We then write to the GPs. And the letter, with these newer transcription services, the letter gets to the GP within a week or 10 days. They can then go to the GP, who can then explain to them what the consequences of the Telegeriatric session were. So that's worked pretty well, and because of the availability of video consults or video sites, I think there's something like 95 sites where you can do videos in WA. So we can move around in one Telegeriatric session from Geraldton to Esperance to Kalgoorlie to Meekatharra with ease, which makes it fairly easy.
Once the diagnosis has been made and the patient has dementia, they then need ongoing support. And some of that comes from the general practitioner, but where does the geriatrician get involved further down the line?
Unless there are major medical problems with their behaviour and so on that are not manageable by the GP. But really, as I said earlier, we depend on the family and the support services, and I appreciate the country hasn't got the wealth of support services that we have in the metropolitan area, but really they are dependent on the local support. I mean, I work in the southwest, and I think they're available elsewhere. There's a group called the Neurological Council of WA who provide nurses who go out, and I think it was initially aimed at patients with motor neuron disease, Parkinson's, multiple sclerosis, but they've extended their brief to include those with dementia, and they will actually go and see the demented patients, help the families through some of the difficulties they have with their behaviour and so on. So very rarely do we get involved again. All right, it's really up to the GP. We leave it to them. I mean, as I said, behaviour is a problem, and there are drugs. We can come to drugs later on, but there are drugs which we don't espouse, as you probably appreciate. We're much happier when the families deal with them and they're in their own homes and so on. If you have to go into care, then we will obviously help them with that, and the social workers and so on. The ACATs help them with that, or assist them with that.
One of the things that happens as a country doctor is that, of course, when the patient does go into residential aged care, you're still their doctor, you're still trying to manage them, and that is where we start to come across problems like requirement for night sedation and requirement for behaviour management. In some of the little places that many of our country doctors work, this is a huge challenge. Have you got any hot tips and any amazing medication advice for the nighttime wanderers and the patients whose behaviour needs modifying?
This is a hot topic, but in fact there's a very good position paper put out by our professional society if you go on the website and type in ANZ SGM, that's our professional society, ANZ SGM, and position paper number 26, I know it off by heart now, is on what we call BPSD, which stands for the Behavioural and Psychological Symptoms of Dementia. And this very nicely describes how we deal with these sort of problems. That's the perfection, okay? But in reality, with your GP in Muckenbuden or Narrabeen who's dealing with this, it's difficult. And really what you've got to do is look for any exacerbating factors, all right? So you might check their bloods again, or make sure that they're healthy anyway, that there's nothing, they haven't got excessive pain or losing weight or whatever. Look at their general health and ensure that they are in an optimum state. And this includes things like looking at urinary retention and fecal impaction. I think we overlook those too often that people have. I've just had a case where somebody was brought into hospital and became very agitated, and it turned out that she actually had urinary retention. She had a post-void blood residual of 900, and that's what made her agitated. So look at their urinary function, look at their bowel function, and look at their drugs. I can't overemphasize looking at their drugs because the drugs have side effects. I mean, the latest issue of the MJ Ost last week, 15th of July, deals with an article by a West Australian group on polypharmacy in old people. And the figures are horrendous. The number of patients who have, in RACFs, residential care, it's estimated that 90% are on too many drugs. And by that we mean more than 5. And we talk of polypharmacy, we talk of hyperpolypharmacy, and we talk of excessive hyperpolypharmacy. So that's 5, 10 or 15 drugs. So you look at their drugs, the side effects, whether they need them, whether there's an interaction between the drugs and so on. Right, what about drugs? We don't like the psychosedatives. The atypical antipsychotics have got side effects, and they produce unfortunate side effects, so we don't use them. The only indication for the use of psychosedatives is if the patient is aggressive. If the patient is aggressive towards the staff or towards other patients, then you might choose to, and if you can't find a reversible cause, you might use the psychosedatives, risperidone, quetiapine, olanzapine. Right. If they have behavioural problems, we don't worry about wandering. Wandering, we don't give them tablets for because all they do is lock the facilities, all right? They should be in a locked facility if they wander, all right? So there's benign wandering, there's malignant wandering, and you don't need to dope them up to control that. I mean, we do have facilities in Perth where we have locked facilities. In the country, I think you would agree there probably aren't locked facilities in most of the nursing homes.
Some, but in larger and more regional centres, which of course then puts the patient well and truly away from their family, which is quite distressing on its own.
And distressing on the other patients in the facility, being in a locked facility. So certainly in Perth, where we can categorise them and put all the happy wanderers in a single facility and lock the doors, that works very well. And you can create pathways that never end, so they can just wander all over the place and manage very well. They're without medications, and you've got a sympathetic staff. The staff know how to handle them. Don't aggravate them. Keep them away from, staff can be quite difficult as well, so the staff have to learn to behave with them as well. All right, so you may use psychosedatives, but I think I've sort of made reference to the only indication of that. Are there wonder drugs? The Cochrane says no, they're not. But there's a very good delirium unit at Sir Charles Gardner, and they use valproate quite a lot, and they use escitalopram. And I work in transitional care, and we had a lady with quite severe dementia who was behaviourally completely inappropriate, pulling the hair of the attendants and so on. We put her on valproate and she calmed down magnificently. So just a small dose of valproate. I mean, there have been some editorials recently about the side effects of valproate, but I think that's mainly in pregnant women that they worry about valproate and the side effects. But certainly small dose, 200 milligrams BD is maybe sufficient to just quieten them down. Escitalopram is used in patients with agitation, is also pretty effective. So although the
You're actually using a moderately activating antidepressant, escitalopram, as a calming agent.
10 milligrams of escitalopram may work wonders together with valproate. I've just got somebody now in TCP who's not threatening people, but in their faces all the time and disturbing the other patients, even though they have Alzheimer's disease. And we've got her on both valproate and escitalopram, and she's quietly and gently, without doping her out and sedating her, she's much improved. So there are tablets. I mean, sometimes people use antidepressants. If I got paid for every patient I saw with an antidepressant with dementia, I'd be a rich man. Too often they're given. But things like mirtazapine is a good antidepressant in a small dose, 7.5, 15 milligrams. So that may be used as well. But I'm espousing the use of valproate and escitalopram, and then with not much emphasis, but acknowledgement that the psychosedatives, the atypical, do have their role. Haloperidol, as you probably remember, used to be my old standby, but haloperidol it's got a long half-life. It's not to be used, and things like clonazepam, all the benzos are out. All right, we don't use the benzos at all. If at all possible, we never use the benzos. And if we have to use the benzos, it's only the short-acting ones, the oxazepam, ativan, and temazepam. But I'm not endorsing them here. We've raised the issue of melatonin. Some of my colleagues like using melatonin. Melatonin is theoretically really only a sedative drug. And I was last year, I think, at a delirium conference in Melbourne run by the Australian Delirium Society, and melatonin came up, and there's no indication for the use of melatonin in delirium. If you want to use it for sleep, then you may, but melatonin is not on the PBS. You have to buy it privately, but I think you can get it through one of the chemists, Price Watch or one of those, for about $1 a day. So melatonin is acceptable as a sleep medication, but that's really all. It's not indicated in delirium or dementia.
Any final words on demented patients in rural areas?
Driving and dementia are a problem, but we will discuss it in our next podcast.
Fabulous. And Peter, any final words of wisdom?
Dementia is challenging, but it really is very rewarding, because you can it's the information for the family that really settles them as to what's wrong with the patients, because there is a condition which I didn't really mention, and I've just remembered. It's called MCI or SCI, which stands for mild cognitive impairment or subjective cognitive impairment. And these are the worried well, who may slip a few points on mini-mental. They may get 28 or 29, but who are independent and manage in the community, manage in their own homes, but who have got a little bit of memory loss. And we know, and this has been, it's defined, MCI, mild cognitive impairment, and we know that about 15% a year seek into Alzheimer's disease. So we will see patients and diagnose MCI, and I followed a few up in the southwest who don't change, who remain just MCI, and who don't change their many mental states and so on. So that forms a part of the group of the worried well, who have this MCI. SCI, subjective cognitive impairment, is just where the patient's worried about it, nobody else is worried about it. MCI is where everybody's or the family of it worried about it as well, and they come to you for advice about it. So those two, and I forgot to mention them in the lead up to discussing a bit further about dementia, but they're important concepts. And MCI is almost seen as a precursor to Alzheimer's. I mean, you probably appreciate that we would like to be able to diagnose Alzheimer's much earlier than we see it. I mean, it's said that Alzheimer's is laid down about 20 years before it actually becomes clinically apparent. 20 years. So,
which puts me in the risk age group, Peter.
Yes, I'm worse than you, unfortunately, but I hope I'm keeping intellectually similar, and I certainly am fit and well. So I'm hoping if I do get dementia, and both my mother and my grandmother both had dementia. So although it's not inherited, I'm very much aware. Look, dementia is common. It's said that we teach the students it's 1% at 60 and 1% for every year thereafter. So by the time you get to 85, 25% of elderly people have dementia. That's how common it is. But you asked me one thing about what one message about it is, that you can impart this to the families and the carers and so on, and reassure them that although they can't avoid it, it's irrevocable, nobody's ever come back from dementia. There are lots of support mechanisms out there, and more the countries, the government is involved in supporting dementia because it's a tsunami. With the elderly are getting more because of the families are smaller now, so the percentage of elderly are getting higher, and ipso facto the number of demented patients are getting higher. I thought I'd just mention a quick thing, that the elderly form about 15% of the population now. In 40 years' time, there'll be 22%. That's alarming. I mean, Japan is the highest at about 20% now of their elderly. And you might ask, what's a definition of an old person? For the government, it's anybody over 65. But we don't use an age-designated policy for admission to the geriatric wards in Charlie's or Royal Perth. We use a disability rated. So you can be 85 and independent and not geriatric, but you can be 50 and a geriatric patient. So it's disability rated rather than age related, and there's an increase in the incidence of old people in the community and in RACFs and so on.
Peter, thanks for joining us today, and I'll look forward to chatting some more with you about other aspects of geriatric medicine.
Thank you. It's been a pleasure.